Today on Cancer Buzz, current and future policy considerations for telehealth.
The statistics for February of 2020, pre-COVID, 0.01% of all Medicare fee-for-service primary care visits were done via telehealth. That number rose to 43% in April.
We explore the policy conversations shaping the role of telehealth now and in years to come. Welcome to Cancer Buzz. I'm your host, Summer Johnson. As the COVID-19 pandemic swept through the U.S. in early 2020, the use of telehealth services skyrocketed across the country. In the first week of March, only 11,000 Medicare patients used telehealth services, and then a month later, a whopping 1.3 million Medicare patients used telehealth in just 1 week. The Centers for Medicare and Medicaid Services quickly made changes to accommodate this surge in telehealth appointments, including more equitable reimbursement for virtual services. Now that telehealth is more widely used, it remains to be seen if it will become a permanent fixture in cancer care. Our guest today gives us a look into the discussions currently happening in Washington and how upcoming policy debates could impact the future of telehealth for you and your patients. Frank Micciche is the Vice President of Public Policy and External Relations at the National Committee for Quality Assurance. His organization formed a task force on telehealth policy this year, gathering a group of clinicians, advocates, and health systems to convince legislators that telehealth should be a staple of American healthcare.
Well, like many people in the COVID world, I think, I had telehealth thrust upon me as opposed to this being a career objective or anything that I was consciously looking to expand into. The National Committee for Quality Assurance, NCQA, where I work, we're involved in measuring the performance of health systems, practices, health plans, et cetera. And so, of course, when COVID struck and folks were understandably unable or unwilling to either provide or seek care in an in-person setting, telehealth became the way in which they did that. And it was really an extremely vital lifeline, as I'm sure you can imagine. But NCQA quickly realized that we were going to have to certainly understand the nuances of how telehealth was being utilized during the pandemic. And then, of course, assuming, and I do assume, that it will be an integral part of the system going forward. So that entailed some deep dives, some conversations with stakeholders across the healthcare system who were either previously very knowledgeable about telehealth or who were being thrust into the use and understanding of telehealth in the same way that, again, millions of us were as a result of COVID. So that was my crash course and really NCQA's crash course on becoming a telehealth, I don't want to say advocate. I mean, what we advocate is the integration of telehealth into the overall healthcare system and into the quality improvement rubric. So I do believe, and NCQA does believe, that telehealth will be a force and a significant mode of providing care going forward. And we think there are innumerable benefits to it. What we are focused on is understanding how best to enable telehealth to thrive, to do the things it does best, how to measure the effect of a telehealth visit, as we are focused on measuring the effects of all healthcare interactions, and then trying to identify ways in which, and this is the exciting part to me, telehealth may actually be a springboard for the system as a whole and for quality measurement into the digital world and open up some opportunities that have previously not been there for measuring and driving quality improvement.
Let's go back to the beginning. Can you describe the regulatory challenges for telehealth pre-pandemic? What had to change quickly during the pandemic, and then where are we now?
Well, so obviously the ability to provide care via digital means. I'm not even sure that's the appropriate term for something as simple as a telephone call, but to provide care without being face-to-face has been around for a long time and has been used for a long time. The barriers to it becoming a much larger part or much more frequent mode of providing care are many, but one of the most significant has been the perception of cost and potentially of fraud or waste or overutilization, the perception that telehealth might induce that or might be particularly susceptible to that. And so for public policy makers, particularly Congress, and particularly when we're talking about the Medicare program and Medicare, traditional Medicare, if you will, rather than Medicare Advantage, which is Medicare provided through health plans. And a lot of those are already in value-based arrangements where telehealth is just another tool in the toolbox for them. And if it makes sense for them, for the plans, and for the patient, they'll use it. Not to say they used it as much as they did once COVID hit, but it was a little more common thing for Medicare Advantage plans to be using it. But for fee-for-service Medicare, there was always this looming what if. What if we open the floodgates on telehealth, we reimburse for it, and we just say, if you as a patient or you as a provider choose to get your healthcare via telehealth, we're going to treat it just like we do any old office visit.
What are the complications that this presented for policymakers?
There was this perception that it would drive cost and waste and overutilization. The way that manifested itself for congressional policymakers was a score from the Congressional Budget Office, which is a little known but extraordinarily powerful entity that basically looks at any policy change or legislation and says, okay, if you want to do this, in this case, if you want to expand the use of telehealth in the Medicare program, here's what we project it will cost. And for the most part, particularly under budget rules that have been in place for a while, though they've lessened a little bit, if you're going to increase the cost to anything, you have to offset it. So folks don't like doing that. They don't like being on the hook for a cost they have to offset. And then, of course, however it is you offset it, which means cutting spending or finding savings in other parts of the program or in other programs altogether, there's someone who's not real excited about having their program or initiative used as an offset. So that has been the barrier, and it was enough of a barrier to prevent any sort of widespread use of telehealth in the fee-for-service Medicare program, traditional Medicare. Like anything, a crisis often drives action in a way that the status quo, the everyday normal cannot. And that was certainly the case here where, because of COVID, Medicare was worried about serving those folks. They weren't as much worried about what CBO was going to say it cost or if they were going to actually spend more, which, of course, in the end, they haven't. And there's a lot of reasons for that I think we'll probably go into. But that was the big impetus, was we needed it. And so we did it. And now we're going to rightfully account for some of those costs. We're going to look at the data, which is exciting in itself, and see if we can identify what works, what doesn't. Is overutilization really a threat? All sorts of things. And that's a lot of what our telehealth task force focused on.
Like you said, we're going to assume that telehealth will remain moving forward into our new normal post-pandemic. For some of those regulatory changes, like being able to practice across state lines, for example, what do you think are the chances that those components remain post-pandemic?
I think, to use a really hackneyed phrase, the genie is out of the bottle. I don't think anyone feels, just as very few people felt comfortable going to the wall in support of expanded telehealth prior to COVID, I think it's going to be almost 180 degrees where you're going to have to make a heck of an argument to prevent policymakers or others from maintaining the changes that were made during COVID. And primarily, those changes were around the restrictions that had been in place. It was extremely restrictive. Again, we talk about Medicare, they sort of set the rules, not only for their own program, but they're a sort of a market setter for practices in healthcare. So Medicare prior to COVID was saying basically you can only perform and get reimbursed for telehealth in the fee-for-service program if A, the person receiving the care lives in a rural setting. I'm not sure exactly how they define that, but we can imagine. And then B, the care can only be provided at approved facilities. So essentially, you are requiring that rural resident to drive to, it could be a community health center, it could be any number of approved locations. And then the provider would be patched in and provide the care at that setting. So you can imagine that rules out pretty much almost all the care. I'll give you a number if it's of interest. The statistics for February of 2020, pre-COVID, 0.01% of all Medicare fee-for-service primary care visits were done via telehealth, 0.01%. That number rose to 43% in April, once everyone was truly bunkered down, and particularly for primary care, which is not urgent, although we stress at NCQA and others do. If you don't get your regular primary care, it becomes urgent. And that's a concern as we're heading into another lockdown, it looks like. So that's a 4,300 times increase in the amount of telehealth primary care provided in the Medicare fee-for-service program. So that tells you both how small a base we started from, and then also how large an amount of demand there was and need there was for telehealth care in the early going of COVID.
On December 1st, the Trump administration extended a payment rule that locked in expansion to Medicare coverage for telehealth services. Can you explain the implications of that, particularly for our audience of oncology care providers?
What they did do in a lot of cases for a lot of the restrictions that had been in place, they said that those restrictions will continue to be lifted through December 31st of the year in which this current public health epidemic is declared. So that emergency declaration has been, prior to the most recent ruling, had been extended into January. So what it does is it lifts almost all of the restrictions that were in place pre-COVID through December 31st of 2021. And I say that assuming that the public health emergency declaration won't extend past December 31st of 2021. But CMS, to their credit, has been a great advocate for telehealth really since day one of COVID, but they don't have the statutory authority to lift those restrictions permanently by and large. There are a handful of places around the edges where they can nibble. So if those changes, if the restrictions that were in place pre-COVID are going to be lifted permanently, it's going to take an act of Congress and a president to sign it into law. And so you're seeing a lot of activity on that front. There are always initiatives, lawmakers, particularly from rural areas, but others who had an interest in expanding the use of telehealth have tried to get bills together. And refreshingly, it's a somewhat bipartisan effort. There's no really political divide around telehealth. There are, as I say, some areas of the country that are more in need of it or more interested in expanding it than others. So those efforts were always underway, but they were sort of bubbling on the back burner, and COVID turned the heat up on those. And so I do think, back to your earlier question, it's very hard for me to imagine this Congress ending and the changes that the Trump administration just made being allowed to go away on December 31st, 2021, without Congress having acted to extend them and maybe make them permanent.
Let's talk about reimbursement parity. How will that unfold in the coming months?
Well, parity that's a tough one. Now, there's where we get into, I don't even know that they're political divides. I don't know that they're ideological divides. They're, I think professional divides. There's sector divides. So if you're an insurer, you certainly are skeptical about a blanket parity policy that says, either from the federal government or the states or whomever, that all procedures that are provided via telehealth should be reimbursed at the same rate at which they're reimbursed for in-person visits. There's no doubt that there is an audience that is very receptive to that proposal. Physicians providing telehealth, for example, but it raises all sorts of questions, and there are no simple answers to what the right reimbursement rate is, how universal any declaration of parity should be, how you even consider what services can be provided in 100% the same fashion versus, in some cases, maybe you could be rewarded even more than in-person rates. But our payment system is so complex to begin with. And to introduce this issue into what is already very much of a mess in terms of how we pay for and reimburse care, that is going to be the real battle. And it may be that battle is fought another day. Let's lift the restrictions perhaps, and then we'll work on how you deal with some version of parity or some version of reimbursement that takes into consideration all of the nuances related to telehealth and in-person care.
Have we received any indications on the Biden administration's position on this?
In terms of the Biden administration, not that I know of, have they taken any sort of position on telehealth, but I can't imagine, again, for the same reasons, that they would want to be the ones who say, oh, yeah, everything's back to normal. We're going to start restricting the use of telehealth. Now, they may have a nuanced position on parity once they have their team in place and they start considering it. And of course, the cost concerns will reemerge. Part of the reason CMS and others have been able to wave the wand and say, telehealth, go ahead, is that it's pretty clear overutilization is not going to be a problem while we're dealing with COVID. There are just so many factors that mitigate against people using care in the ways that they did prior to the pandemic. So we're not going to see massive increases in cost for insurers, for example, or for the federal government in the case of Medicare, based on overutilization during the pandemic. The fear is honestly much greater, the care that's been foregone and the effects of not having regular care provided in traditional ways and what that'll cost the system, and particularly what it'll cost patients in the way of pain and suffering and unfortunately death. So we haven't had to deal with the cost part of the telehealth debate right now. And I do think the momentum's strong enough that whenever that topic is taken back up, policymakers will find a way to deal with it that ideally doesn't break the budget, and I don't think it would, but also that recognizes that people want telehealth, providers want telehealth, systems and plans want to be able to offer telehealth more easily. So I wouldn't expect the Biden administration to have any sort of firm position other than to say that it's clearly been a lifeline. It's going to be a lifeline because this pandemic will not be over before they arrive in office, and then down the road they'll clarify exactly where they want to go.
We talk a lot on this show about healthcare disparities, and one of the fears about telehealth is that it widens those disparities. What do you think can be done to make telehealth more equitable?
Yeah, this is a huge concern, not just that there are populations who really don't have any sort of reasonable access to either the technology or the ability to use telehealth. So I think that there are a few things that are clear about how we do this now. What's not clear is how we pay for it and who should be doing it, et cetera, as, that's sort of the devil in the details of this. But clearly, we need better infrastructure in terms of wireless and broadband, and we need it particularly in the areas that are currently underserved. I think rural is an obvious one. I think folks realize that there are surprisingly large swaths of the country that struggle for broadband or wireless access. It's interesting that there are challenges in urban areas as well, including broadband and Wi-Fi to some degree, but also for, and this applies certainly in rural areas as well, but if we're talking about for lower income populations, I think many of us take for granted that you can just connect to the internet on your phone or your computer or however, and we don't think of a meter running in the back of our head, but there are plenty of folks who buy their access to the web by the minute and who are worried about that and who either may not have the resources to buy enough to really engage in consistent telehealth. So that's a concern. There are technology concerns in terms of in an emergency, yes, a phone, a non-video visit is better than no visit at all. And there may even be visits that are as well or maybe even better.
Let's switch now and talk about the task force on telehealth policy. Tell us about it, why it was created, who was involved, and what the work looks like.
Sure. The task force was a offshoot of the conversations I referenced earlier that we were frantically having to try and understand what was going on in the way of telehealth, the provision of care via telehealth, and how we could measure it, how we could make sure that it was highest quality possible, how we could drive quality improvement in it going forward. So all of those led us to talking with a lot of really smart people who were engaged in the system. And at a certain point, we said, probably we're not the only ones feeling around in the dark here. Maybe we should get a group of organizations and individuals together and see if we can't, A, get our arms around what's going on currently, and then B, make some consensus recommendations that involve stakeholders from a number of different sectors in healthcare about what policy in particular is needed. And primarily we were focusing on the federal side in order to make sure that we continued to get all the benefits, both during the pandemic and beyond, of the many positive aspects of telehealth, and that we mitigated any of the risks that we could identify. So NCQA partnered with the Alliance for Connected Care and with the American Telemedicine Association, and the three of us were the conveners. So each of us invited a handful of organizations or individuals that we had been working on or have consistently been working with regarding telehealth. And we had about 20 folks who joined us. It was really a remarkable group. We had Regina Benjamin, who was previously the Surgeon General of the United States. She's now practicing in Alabama, practicing a good deal of telemedicine as part of that, particularly during COVID. We had folks from the various telehealth platforms, which I think, sometimes get lost in the equation because they're not actual healthcare organizations per se, although they've got smart healthcare people involved, chief medical officers on down. But we got them involved because telehealth doesn't work, especially on a wide scale, without very good interoperable, ideally, platforms that enable it and then enable the system to get the data and all the other feedback that's necessary to learn and improve on care. So we had those folks there. We had health plans like Kaiser Permanente. We had Humana. We had folks who were in the ACO and health system space from Stanford, Intermountain.
I understand the National Council for Behavioral Health was also involved. How do mental health and other psychosocial services, which are a key component of cancer care, how do they fall under the umbrella of telehealth services?
That's probably the unvarnished success story of telehealth, is the amount and quality of behavioral health care, mental health care that's been provided via telehealth. It is just so perfectly suited to the technology. In fact, again, as part of the task force, we heard people say that in some interesting ways, many people are more inclined to do behavioral health, to get care for mental health issues via telehealth because, in some cases there's still a stigma there. And the fact that they didn't have to walk into a building that said Dr. So-and-so's office is here, and the fact that they didn't have to sit face-to-face, person-to-person in either the waiting room or when they got in with the doctor or the clinician, that allowed them a lot more comfort, not to mention the convenience. I think we don't always prioritize behavioral health care the way we do our physical health. And so it becomes a question of, do I have time for it? And telehealth obviously makes that a little bit less of a concern. So anyway, we had just an incredible group of folks who came together, and we spent, I think it was 7 or 8 sessions throughout the summer. I was so grateful. We are so grateful that these incredibly talented and busy and influential folks were willing to give up that amount of time in what was a strange summer to begin with.
Could you summarize the policy recommendations given by the task force?
Yeah. So, we started with, going back to one of your earlier questions, what do we do about the restrictions that had been lifted as a result of the public health emergency and that had been lifted individually in a number of states? And our overarching conclusion was they should all be made permanent, with one exception, that being the suspension of some of the HIPAA rules, because, in some ways, privacy is even more, I don't want to say more at risk, but more sensitive in those telehealth settings. So that should certainly be reinstated, the task force said, but otherwise, let's go. We've seen how this works, and it works well. And some of the concerns that had prevented it were, to our mind, overstated. So that was one. Another was that we should do whatever we can to make sure that the data that's generated in the course of a telehealth visit is incorporated into the existing traditional in-person system and how we collect data there. But we also urged policymakers to think about whether there is a way in which the digital nature of these telehealth interactions made it more likely or more possible that data could be shared more broadly. This has been a sticking point going all the way back to the Stimulus Act in 2009 that paid for all these EHR systems, and yet they still, 11 years later, can't communicate with each other. So maybe telehealth offers opportunities to bridge some of those gaps and to make some advances there.
What were some other areas addressed in your deliberations and then recommendations?
We also talked about how you make sure not only that fraud, waste, and abuse, which again has been one of the barriers folks have put up against more expanded telehealth, that the lessons we've learned for in-person care are translated and where necessary, amended to apply to telehealth, but also explore whether there might again be some ways in which fraud and waste are more detectable and more likely to be rooted out because of the digital nature of a telehealth visit. And then overarching everything, we really wanted to make sure, and this is something providers feel strongly about, but I think everyone does when you sit and think about it, we don't want to put more burden on the telehealth system to do more things or to do things better than we expect of an in-person visit. I think sometimes there's this magic bullet thinking that, somehow technology, and in this case telehealth, will fix all of those problems that have plagued healthcare for decades. And we wanted to make sure that telehealth providers were held to the same criteria and standards where there were unique instances that required a differentiation from existing quality standards and protocols, that those be the exception rather than the rule, and that they be closely tailored so as not to increase burden, if at all possible, on telehealth providers.
Lastly, how would you translate the findings of the task force report? Are there any specific recommendations for addressing the challenges that providers encounter in their practices?
Well, I go back to this fear that somehow, while it may be, the vital lifeline for the system as a whole, and that it may be the future for healthcare or a big part of the future for healthcare, that in the end, providers are going to somehow be stuck with even more burden and more expectations that they may or may not be able to control. So I would say doctors and clinicians and the medical community do not want influence in policymaking circles. So I think they should wield that influence wherever possible. Obviously, I can't imagine there are many physicians or clinicians or specialists or anything else who don't want to see us take advantage of the obvious benefits of telehealth. So it certainly shouldn't be, and I'm sure it wouldn't be, a defensive posture here. What it would be is to make clear what those concerns are about additional burden or about being treated differently somehow as a result, and inherently more negatively as a result of a visit being conducted through telehealth. And then really, these are the experts. These are the people who understand the practice, not the theory, of how technology and telehealth and remote patient monitoring and all the other variations can really make patients' lives better. So those experts need to be on the front lines of the policy debate, and they need to make clear what works, what doesn't, what their concerns are, and how we might mitigate those concerns while still moving forward with telehealth.
ACCC has created a new initiative this year to help cancer programs adopt, expand, and strengthen their telehealth practices. You can find a link to that initiative in the show notes. Thank you for joining us for today's episode of Cancer Buzz. If you've been enjoying the show, make sure to subscribe and leave us a review. You can also share this episode with a colleague. Please help us spread the word about the show. We'll be right back here in the new year with more on the latest in cancer medicine, research, and policy. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.